Good morning. Welcome to Grand Rounds. I'm Cynthia Wetmore. I'm the division chief for HEMONC, and I'm very happy today to introduce one of our own faculty, Dr. Sanjay Shah. Dr. Shah did his initial training in Bombay, India. He then came to the United States, where he did, by invitation only, transfusion fellowship in Louisiana at the Children's Hospital in New Orleans. He then went to Henry Ford Hospital in Detroit, where he completed his pediatric residency, and then stayed up in that area of the country and did his HEMONC fellowship training at Wayne State. Sanjay worked as a pediatrician and practiced some HEMONC in Kentucky for a number of years before coming south, and it was on faculty at Banner University, Banner Medical Center for a number of years before we were fortunate enough to recruit him to Phoenix Children's Hospital in 2010. Dr. Shah is currently an associate clinical professor at the University of Arizona College of Medicine, Phoenix, and he serves as a PI on a number of institutional studies here for treatment of children with sickle cell disease. He also serves on the board of directors for the Arizona Sickle Cell Association, and is well known for his work both here and throughout the state. Thank you. Welcome, Dr. Shah.
Thank you. Hello, can you hear me? Thank you. Thank you so much for that wonderful introduction. It's an honor to be able to speak here. I always like to know who I'm talking to, so how many residents, fellows, faculty, anybody from administration? Thank God. All right, so my job is to highlight the advances in sickle cell disease management. I'll have to cover some of the basics to get there. I have no conflicts to disclose. The objectives are to drive home the point that sickle cell is a multi-system disorder. It causes life-limiting complications. We have preventive therapy for most of those complications, and to understand the new physiology, pathophysiology, and treatment of sickle cell disease. So I'll start out with a case. It's hypothetical, but this is fairly typical of what we see. The 1-month-old baby who's named Destiny Hope. The parent, single parent, mom, grandmother come to us because they're devastated. The baby has sickle cell disease on the newborn screening. They want to know what's in Destiny's destiny and what can they hope for. What would her life be like? Would she be in pain all her life? Is there a cure for this miserable disease for her? Should I be telling her, giving her hope, or scaring them? Should I be telling them about the 23-year-old that we lost 4 days ago in our ICU from severe pulmonary hypertension, infective endocarditis from Candida that she acquired from drug abuse, which ultimately killed her? Or should I be telling her that many of the sickle cell disease patients will never have pain? Should I be telling them that there are only 2 medicines approved for sickle cell disease, or there are 40 more in pipeline to be approved soon? Should I be telling them that there's a cure and transplant, or the transplant is only available to a minority of the patients? So there are a lot of, should I be scaring her? Should I be giving them hope? And so in the next 45 minutes, I intend to create a case for hope. So it's not such an old disease. It was described in 1910 by Dr. Herrick, who first described in a dental student, Dr. Walter Clement Noel. He described these elongated cells, called them sickle-shaped. That's where the disease got its name. And those slides are from the original presentation, original paper. And that's his tombstone in Granada. He went back to Granada, practiced dentistry, and then died of a sudden death at 32 years of age. And the sudden death was called pneumonia at that time, but it probably was acute chest syndrome or pulmonary hypertension, which is known to cause sudden death. It's the most common genetic disorder 1 in 12 African Americans have sickle cell trait, 1 in 365 sickle cell disease, 100,000 Americans have, mainly African Americans have sickle cell disease. 300,000 newborns are born with sickle cell disease worldwide. Most of them are born in sub-Saharan Africa, Nigeria and Congo being the most populous states. It was not until 40 years later that we knew the molecular pathology that was described by Dr. Linus Pauling as single gene mutation, substitution of 6 position of beta globin chain, which results in sickling. But even for a monogenetic disorder, it is astounding clinical variability. There are kids who never have any problem, and then there are kids who are sick very, very early in life. So these are the phenotypes. If you inherit 2 S genes from each parent, then you have SS. If you have S and C, then you have SC, and so on. And the ones with the red arrows are the most severe ones. When we talk about sickle cell anemia in literature, we are usually talking about the top 2, sickle SS and S beta 0 thal. Unfortunately, SC, which makes up for 1/3 of the patients, is hardly any literature comparable to SS disease. So we have really long way to go taking care of the whole population. So the clinical manifestations. The clinical manifestations are wide and varied, and they are well known to many people. So chronic hemolytic anemia, it causes severe chronic hemolytic anemia, especially in SS kids, hemoglobin 6 to 9. The body adjusts to it. The anemia itself is not so symptomatic, but the hemolysis causes a lot of downstream problems. The hallmark of the disease is a vaso-occlusive pain episode which causes bone infarction, recurrent pains, and could be debilitating. It causes acute chest syndrome, which is a syndrome of sickling in lobar segments of the lung, which is contributed by sickling, maybe fat embolism, and sequestration of blood there. It can lead to acute sudden death. Infections are caused by hyposplenism. So early in the course of the disease, the spleen autoinfarcts, you're predisposed to capsulated organism infections, leads to sepsis and early death. Used to be the major cause of death in early 1900s. Stroke happens in about 20% of sickle cell children, 15% of the sickle cell children by 20 years of age if it's not prevented. There is sickle cell anemia, SS or S beta 0 thal. Priapism occurs in adolescence, can lead to impotence. Growth failure used to be a common thing early on, but now with good nutrition, that's not a common feature. Splenic sequestration is the early complication where the spleen suddenly pools blood and causes hypertensive shock and can lead to death. But that's not all. There are many more complications. So it can cause osteomyelitis, commonly by salmonella and staph. It can cause gallstones early on in life. It can cause hepatic sequestration or sickle hepatopathy, where suddenly you have acute liver failure from sickling complication. Can be fatal. It can cause leg ulcers in older individuals, oligospermia in males, avascular necrosis of hip and shoulder and other joints. It can cause acute multi-organ failure and death, usually associated with acute chest syndrome, common in adults. It can cause proliferative retinopathy, which causes blindness if it's not treated early. It can cause renal tubular damage. So the renal tubular damage starts early. You lose your concentrating ability early on in life. It causes enuresis, hyposthenuria, glomerular hyperfiltration, albuminuria, and chronic renal damage. And it can cause complications with pregnancy. It looks like a lot, but there's more. It causes chronic pain. Chronic pain is a very poorly understood concept. A lot of chronic pain patients are called sicklers, frequent flyers, drug seekers, you name it. I've been guilty of doing that too. When you have recurrent acute pain episodes, your central and peripheral nervous system gets sensitized, and you perceive touch, temperature changes pain. And some of the chronic pain patients have pain 90 to 100% of the days of their life. It's a miserable thing to have. It causes pulmonary hypertension. So obstructive sleep apnea, hyperventilation, reactive airway disease, predisposed to pulmonary hypertension. It's multifactorial. Chronic thromboembolism also contributes to that. It can lead to sudden death. It can cause chronic kidney disease. It's caused by sickle cell damage, but it's also caused by us. We give them NSAIDs. Every time they come with pain, we give them high doses of NSAIDs. They are dehydrated, give them high doses of ibuprofen, Toradol, and we contribute to that chronic kidney disease. It causes silent strokes. So about 30 to 50% of adults have been shown to have silent stroke with SS. It causes neurocognitive decline, which is unrelated to stroke. It causes red cell alloimmunization. So you develop red cell antibodies. To 30% of the sickle cell adults have red cell antibodies. You can't transfuse them. They'll cause delayed transfusion reaction. Sometimes it leads to death. It causes iron overload. Iron overload causes downstream problem in endocrine organs. Many sickle cell patients throughout their lifetime get intermittently transfused, and before we know it, they develop iron overload, and it gets missed because nobody's looking for them. It causes right heart failure from pulmonary hypertension, and it also causes left ventricular diastolic dysfunction. It predisposes you to autoimmunity. I have a girl who has sickle cell, stroke, chronic transfusion, iron overload, autoimmune hepatitis, ulcerative colitis, and a right atrial thrombus. And it causes sudden death. I had many more, but I think you'd walk out. So it causes this chronic multi-organ failure that is inexorable and leads to early mortality. It causes social catastrophe. It doesn't affect the child, it affects the whole family. So this is our old concept of pathophysiology of sickle cell disease. We were taught that sickles, nice round red cells, get pointy, get stuck in the blood vessel. It causes occlusion and infarction. But we've understood much more in the last 2-3 decades. Based on that, this is how we treated the sickle cell disease. We gave them hydration, we gave them pain medicines, we gave them transfusion if they were anemic, we gave them more pain medicines, we gave them chronic transfusions if they had stroke, we gave them antibiotics if we were fearful of infections, and then we gave them even more pain medicines. For 20-30 years, that's all we did, and sometimes I feel I still do that. But now we have new understanding for the last 2-3 decades. So this slide shows that you have sickling, which causes hemolysis. The hemolysis causes release of free hemoglobin in the circulation. The free hemoglobin in the circulation scavenges nitric oxide. So you have nitric oxide depletion, which causes vasoconstriction. The free hemoglobin hemolysis also releases free reactive oxygen species in the circulation that causes inflammation. Both those things cause activation of the adhesion molecules on the red cells, white cell, and platelets and endothelial cells, causing clumping of those cells and vaso-occlusion. It causes this inflammatory stimuli, which causes WBC activation, endothelial cell activation, and platelet activation. Those are the pro-inflammatory, it releases pro-inflammatory cytokines and expresses these adhesion molecules. And then finally, it causes activation of coagulation cascade. So we have this new understanding, and how are we leveraging this new understanding? So we figured out the poor prognostic factors in sickle cell disease. They are not accurate, but at least it gives us some idea about who is going to behave badly. So severe anemia is bad. Low hemoglobin F is bad. High white count is bad. High retic count and high LDH are bad. So we know what are the poor prognostic factors. Based on this is our dream preventive therapy. A little wordy slide, but I think it was important. I left it in. So a dream agent would be a single agent, inexpensive, orally administered agent. It would affect all the parameters I just described. It will increase the hemoglobin F, it will decrease the anemia, it will decrease the white count, reticulocyte count, and LDH. It will be clinically efficacious in decreasing the pain episode, fewer pain episodes, fewer hospitalizations, decreased hemolysis. It will be effective in all age groups, prevent some chronic organ damage. It will benefit, will be sustained over a lifetime. It will have few short-term toxicity, and no major long-term complications. So that's a dream to have. But fortunately, we have the dream come true. We have an agent that meets pretty much all of that criteria. So that is hydroxyurea or hydroxycarbamide. It is an inhibitor of ribonucleotide reductase, which inhibits cell synthesis, and it works in these many ways. So it increases your fetal hemoglobin, it decreases your white blood count and platelet count, it decreases adhesiveness of neutrophils and platelets, it increases the MCV and hemoglobin F, and by doing that, increased hemoglobin F in the cell will decrease the concentration of sickle hemoglobin, will decrease sickling and hemolysis. And the hydroxyurea molecule is basically urea with one H substituted by a hydroxyl group. So when it's metabolized, it releases its nitric oxide, and that makes the nitric oxide more bioavailable. So all those things contribute to the effect of hydroxyurea. It's like just made for sickle cell. You shouldn't be using it in CML anymore. So this is the timeline for development of hydroxyurea. The first proof of concept trials were done in 80s. Multi-center sickle cell hydroxyurea trial was published in this landmark paper in 1995, which showed the effect of hydroxyurea in decreasing the frequency of pain episodes. And these were the conclusions, that it can decrease the pain episodes. Full benefit is not achieved for several months. But it also said that maximum tolerated dose is not necessary. But we now know that it's a good idea to do that to prevent chronic organ damage, and that the long-term safety is not established, but we've now established long-term safety too. So this is how we did it. In 2000s, we published infant USOF trial and then extension of the USOF trial, which demonstrated benefits in infant. Extension of the MSH follow-up trial, which showed long-term efficacy and reduced mortality in adults, and then long-term sustained benefits in children. So by early 2000, it was the established agent and approved for use in sickle cell adults in 1996, I believe. So these were the benefits of hydroxyurea. It decreases pain episodes, it decreases need for transfusions, it decreases long-term and organ damage, it increases longevity, and it only provides partial protection against stroke. It does not prevent stroke. And there's no real data for ST disease. The trials for ST disease had to be stopped early because of poor accrual, unfortunately. So it's very well tolerated. It does not cause leukemia like many lay people fear. It does reduce pump count, but oligospermia is a known effect of having sickle cell disease itself. It does not cause genotoxicity. It does not cause fetal malformation. Pregnant women in the MSH trial delivered normal babies. The current recommendation is to start hydroxyurea in SS and S-beta-0-thal patients at 9 months of age, or at least offered it to them. So why do we have no universal use of hydroxyurea? There are a lot of barriers to use. One is lack of the provider buy-in. Providers who take care of sickle cell disease are far and few in between. Many sickle cell patients don't have access to providers to take care of sickle cell. So many providers don't feel comfortable. They don't believe, they are not convinced about the benefits of hydroxyurea. There is a fear of using chemotherapy lifelong. There are socioeconomic barriers. Many families are single, unemployed parents, hard to come to hospitals regularly. They have many more other priorities in their life than using a preventive therapy. And then there is, I think this is the biggest drawback. It is generic and cheap. You will not see a 2-minute ad in primetime TV for hydroxyurea. Nobody has interest in promoting, no financial interest in promoting it. So only providers which are motivated promote it. So what have we done to fix this? We are part of these regional and national collaborative networks where we reach out to providers to educate them about use of hydroxyurea. I've provided education to our nurse practitioners, other physicians, emergency room. We have involved our Arizona Sickle Cell Foundation to create a network. We have our yearly World Sickle Cell Day celebration, so families come together, they talk to each other, they understand the benefits of preventive treatments. And then we have our wonderful IT folks to help us with creating IT solutions. So we have made some Quippe note changes which force providers to address whether somebody is eligible for hydroxyurea or not. If they are eligible and if they are not on hydroxyurea, we are trying to capture why they are not on hydroxyurea. We can address those barriers in future. If they are on hydroxyurea, we have created this table that makes it easy for the providers to titrate the doses, monitor the long-term changes. We expect the hemoglobin F to go up, the MCV to go up, ANC to stay in the right range. And for those who are not comfortable, we have provided them table within the note to guide the dose modifications, so we can achieve the maximum tolerated dose. So the second big area of impact is stroke prevention, which in last 20 years has made a big change. So burden of stroke is large. 15% of untreated, unprevented sickle cell patients will develop stroke by 20 years of age. 50% of adults have evidence of silent stroke, neurocognitive decline that I described. The stroke happens primarily because of large vessel disease. So it is the narrowing of the internal carotid, middle cerebral, intercerebral arteries. And it has a long prodrome. So it becomes symptomatic only after it's been going on for some time. That provides us an opportunity to pick it up early and prevent it early. So that technique is called transcranial Doppler. So this is an ultrasound technician using a high frequency probe to interrogate the circle of Willis. And so they measure the velocity at the base of the brain in the internal carotid, middle cerebral, anterior cerebral, and posterior cerebral arteries. And there are standardized values for that. So if there is narrowing of the artery, just like a garden hose that is squeezed, shoots out the water farther away, the narrowed artery would have increased velocity in it. And then there are standardized numbers, and if it's beyond the standardized number, it's considered abnormal. So based on that, this TOP trial was conducted, which shows that it can prevent stroke. Transfusions can prevent stroke in kids who have abnormal transcranial Doppler. So they screened 2,000 children, and those with abnormal TCDs were either randomized to receive transfusions or no transfusions. There were about 130 of them, about 6.5% incidence. And after 1 year, only one out of in the transfusion arm got stroke, as opposed to 10 children in the control arm. And this is the long-term follow-up of that study, and you can see by about 3 years, 25% on the non-transfused arm had a stroke. So big impact, and hardly any in the transfused arm got stroke. So it's a very effective preventive strategy. We have an effective screening tool for this. So these are the current recommendations. All the kids between 2 and 16 should get yearly transcranial Doppler. Those with abnormal will get further studying, and if they are found to be abnormal, will get chronic transfusions. So we have an effective strategy. Why don't we implement that? So the problem is many children with sickle cell don't come for their regular follow-up. They come only when they are sick. When they have myriads of other competing things asking for our attention. They don't come for their hospital follow-ups when we can address those situations. And scheduling a radiology study is a nightmare, to put it lightly. Sometimes even the best intentioned parents have a hard time getting it scheduled. So what have we done to fix this? Again, I reached out to our IT folks, and I have to thank Vinay for creating this. This is the product of last 6 weeks of hard work. This gives us a sickle cell dashboard, gives us a real-time snapshot of all our sickle cell patients. So we have 304 sickle cell patients, 10 of which were recently admitted, who are currently admitted, who had ED visits, how many percentage had hydroxyurea, how many percentage have had their TCD done. So at a snapshot, you can get the idea. And then if you click on the Show Details tab, it gives you these details about the patients. So we know in the last 2 weeks, 10 patients were discharged, and of these 3 are missing the follow-up appointment. And this, at a glance, gives my nurses, medical assistant, an opportunity to make sure they come for their follow-up, make sure those who are not scheduled get their follow-up scheduled, and then address deficiencies at that time. For TCD, we created a separate tab where in this it can give us a TCD for our entire population or for population that's coming in the next 2 weeks. So here it shows that there are 22 patients that are coming in next 2 weeks, out of which 14 are between 2 and 16 years of age. 11 are eligible to get transcranial Dopplers, out of which 3 are missing the transcranial Dopplers. And those 3 are outlined here, so we know when they're coming, who are they seeing, and so we can reach out to those providers. It also tells us who will be needing transcranial Dopplers in the next 2 months. So we can prospectively schedule those patients as they come to us. So this is a marvelous solution to get to 100% within the next year, and that's our goal. This gives a snapshot of an individual single sickle cell patient in real time. So this is a complicated patient. In the last 2 years, this patient has had 37 ambulatory visits, 10 admits, 5 ER visits, and has seen 14 different attendings. It tells me at a glance that whether they've seen their ophthalmology docs or not, and how many times they were seen by oncologists versus a hematologist. And I believe that seeing a fewer number of providers helps the families connect with them, and they're more likely to follow the instructions if they're seeing the same providers more often. It also tells me that this patient is already on hydroxyurea and on transcranial Doppler. In future, we'll capture things like whether they've had their immunizations all scheduled, whether they got their flu vaccines, whether they're on transfusion therapy, whether they're iron overloaded. There's a ton of things we can capture through IT solutions. This is a nice pictorial that Vinay created, and if I click on the yellow buttons, it at a glance tells me that 16 of our 301 patients have had a diagnosis of stroke in the last 2 years. So that helps us target that population for studies, for intervention, for prevention, and all that. So what used to be a tedious process of going through all the charts, creating Excel sheet, this in one snapshot, we are able to capture all that. So this is, I have to thank Vinay for that. How about a cure? So stem cell transplant in sickle cell disease is a cure. Basically, you give myeloablative chemotherapy to the patient and give them stem cells from their sibling donor or other alternative donor. This is analysis of 1,000 patients in European and international registries, which shows that more than 90% survival rate from HLA identical sibling transplant. The cord transplants didn't do as well, but this is a very effective curative therapy. So if we have something like that, why don't we cure everybody? So only 18% of sickle cell patients will have a HLA-matched sibling donor. Transplant is perceived as risky, even by me. It can cause chronic complications that could be lifelong. And then there are some families who are not ready for transplant. They have their own social situations which make it very hard for them to undergo transplant. Some families see the benefit of hydroxyurea, chronic transfusion therapy, and don't see the need for transplant anymore. So that's why not all the patients are transplanted. So I will discuss the new therapies next in the next few minutes. These are the therapies in clinical trials. There are 200 trials occurring for sickle cell disease nationwide. And to recapitulate, these are our targets. First target is the adhesion molecules on white cells, endothelial cells, red cells, increasing the nitric oxide bioavailability, increasing hemoglobin F concentration, and then targeting inflammation and hypercoagulation. Out of which the adhesion molecules are the most promising targets, and this cartoon shows which agents are being tried. So The neutrophil adhesion starts with rolling of neutrophils, which is mediated by this E and P selectins. Once rolled, it adheres to the endothelial cells, activates some other cascades which capture platelets, capture red cells. And also the red cells by themselves adhere to the endothelial cells and activate adhesion molecules on the endothelial cells. So rivipansel and crizanlizumab is the adhesion molecule targets. I will discuss them separately. But IVIG decreases the red cell capture. Antiplatelet agents have been used, and then some anticoagulants which modified properties. So they don't have the anticoagulant property as much, but they have the anti-P-selectin property that helps with their action. So rivipansel is the most promising agent. It's a pan-selectin inhibitor. In the murine model, it was shown to arrest the vaso-occlusive crisis. So they studied it in 76 sickle cell disease patients during their painful episodes. And it was a multi-center randomized placebo-controlled double-blind trial. It was given every 12 hours for a total of 7 days. So what it shows is the benefit. This graph shows the mean hourly opioid use by the day. And it decreased the opioid use right from day 1 by 80%. So this is the control group, and this is the testing group, and you can see the drop in opioid use right from day 1. And this was true even in chronic pain patients. So this was really amazing results. It decreased the time to resolution of vaso-occlusive episodes and improved the time to oral analgesics. Because of small numbers, these were not statistically significant. This was statistically significant. This is the other agent, crizanlizumab, which is used for prevention of pain. This is a P-selectin inhibitor. It was tried in adults. It included SC patients, which was very good. It also included hydroxyurea, so it allows us to assess the additive benefits of that agent. It used 1:1 ratio to randomize to low dose, high dose versus placebo, and it was blinded and randomized. So it was given 2 weeks apart and then monthly for a whole year. And these are the time to the first painful episode and time to the second painful episode. And it prolonged the time to the first episode and the second episode in a statistically significant way. Sorry. And it decreased the vaso-occlusive episode by 45%. We're about to open this trial at our center. So the next target is the inflammatory pathway and the nitric oxide pathway. So nitric oxide downregulates all these adhesion molecules, and by its effect on the cyclic GMP pathway, it causes vasodilatation. So you can improve this by providing the substrate for nitric oxide, or by modifying the nitric oxide metabolism by statins, or by directly affecting the cyclic GMP pathway, or the phosphodiesterase inhibitor pathway, the sildenafil thing. Also glutamine, separate from the nitric oxide pathway, increases the antioxidant effects by producing more NADH. So glutamine is a conditionally essential amino acid. What that means is when you're stressed, you need extra glutamine. And it produces the NADH and decreases the oxidant damage. So that was one of the agents that was tried and is approved. This is the second agent that's approved for sickle cell disease, L-glutamine. In 230 patients, mainly adults, randomly assigned to either receive glutamine or placebo. And it reduced the number of pain episodes by 25%, 30% lower hospitalization rate, and reduced acute chest syndrome. And this benefit was also seen in kids who were already on hydroxyurea. So the benefit was additive. Unfortunately, many insurance companies don't approve it. It's about $10,000 a month. This is the time to the first painful episode and the second painful episode, and both were prolonged on glutamine. So good promising results. And then the inflammation pathway. So these agents are known to us, the Singulair, xylitol, omega-3 fatty acid, and inhaled steroids, all downregulate inflammation. Sickle cell is the chronic inflammatory state, and downregulating that helps prevent thing. And all these agents are in some phases of trial. This is a promising monoclonal antibody, canakinumab, which is the IL-1 beta antibody, which is going to be tried as a preventive treatment, just like risankizumab. So that is also in phase 3 trials. The other target is hemoglobin F, of course, and apart from hydroxyurea, we can target the FOX3 pathway by metformin, the histone acetylation pathway and DNA methylation pathway. By blocking that, you can increase the hemoglobin F production. And there are several agents, and so these would be useful for folks who don't respond to hydroxyurea very well. These agents target the sickling directly. So the voxelotor or GBT440 is an agent that goes and binds the sickle hemoglobin. It increases the oxygen affinity of the sickle hemoglobin, so it doesn't allow it to get deoxygenated or sickle. The sanguinate is a bovine molecule that donates oxygen and carboxyhemoglobin to the sickle hemoglobin, again preventing its sickling. And again, these agents have shown promising early results. This is a botanical with poorly understood mechanism of action. And the ultimate promise is the gene therapy. But before that, I want to go back to this. So I described all these targeted agents that target all this, but we have hydroxyurea that targets everything all at one time. So the first goal is to optimize the use of hydroxyurea before we target all these separate pathways. So the promise of gene therapy, that would be the ultimate cure for, and it would be available to majority of the patients. So we've created lentivirus vectors that can be transfected. These results were published in the recent ASH meeting in December. The patient becomes his or her own donor. You collect bone marrow, select out the stem cells, CD34 positive cells, transfuse those cells with lentiviral vector, which carries the normal hemoglobin A gene with slight modification that allows us to track that, and then it is cryopreserved. Then the patient gets myeloablative conditioning regimen, which is like mini auto transplant, and then they get infusion of their cryopreserved cells back and hope that some of those cells will express the hemoglobin, normal hemoglobin A. And this is the results from that. So after 3, 6, 9 months, the viral copy numbers as opposed to the diploid genome is persistent. So there is sustained expression of the virus vector. And more importantly, after 3, 6, 9 months, about an average of 5 grams per deciliter of hemoglobin is the normal hemoglobin A. And so after 6 months, you converted a hemoglobin SS patient to the sickle cell trait patient with few complications. So that is a curative treatment that we could have. So for Destiny, I can give their parents hope that I can tell her that in 1910s, when it was initially described, most of the infants succumb to the disease early on in life. In 70s, National Sickle Cell Anemia Control Act was enacted. As a result, penicillin prophylaxis and newborn screening became mandated, and the survival skyrocketed. And with hydroxyurea and stroke prevention trial, the current survival stands at about 42 to 45 years for sickle cell SS patients. That pales in comparison to some centers from United Kingdom who demonstrated a median survival of 65 years, which is a huge jump. We have a long way to go, and they've done that by coordinated, focused sickle cell care in one center. So we have a scope to achieve that. These are my collaborators, Joanna, Esteban, Christine, Angie, and Laurie. They keep me motivated. They keep me on track. They are a very passionate group of people. That we have a weekly sickle cell meeting where a lot of progress is made in understanding. We teach each other, and we catch each other doing wrong things, so we can improve. That is the truth. It's usually me who gets caught. Brooke is our sickle cell program coordinator. She has been instrumental in keeping us motivated. Darcy, Becky, Michelle are her supporters. Michelle is our social worker. We need twice the number of people, so we're going to beg to get more people. Our data coordinators, Erica and Courtney, and Sue, who keeps our meetings on track. And finally, our honorary members, Vinay and his team, who has really created a huge success for us in the last 2 months. Thank you.
Tried or helped?
Sorry?
Inhaled nitric oxide, has that helped?
So we tried for if somebody is in ICU with severe pulmonary hypertension, they will be on inhaled nitric oxide. But I'm not aware of its use outside of ICU setting. Thank you.